So I do remember that Thomas Bieber had a presentation back in 2018 at the IZ in Utrecht, and one of his slides said, "I had a dream," and I do remember sitting there thinking, well, I had mostly the same type of dreams about biomarkers. So I think it would be interesting to discuss some of the topics that he discussed back then. So biomarkers for endophenotyping that can result in better prediction of treatment response, objective biomarkers for disease severity, but also biomarkers that predict disease trajectory. So basically in infants, what happens? Will a kid get asthma? Will a kid get rhinitis? And then maybe we can end with the minimally invasive biomarkers like the tape strips and the dry blood spots that can be used for different types of topics. So let's get started.
Yeah, no, absolutely. It's a very exciting topic for all of us, I think. And particularly, I think it's exciting because even though we have already good drugs for atopic dermatitis, none of them achieve 100% or even close to 100%, right? We are not at the stage that we are at psoriasis. And I think in order to get to that 100%, we need to really identify the super responders, or the non-responders with different drugs, so that we can basically get to a personalized medicine in which we will be able to apply the right drug for the right patient. And I think
exactly. Yeah.
In my view, that's where we will go in atopic dermatitis. In psoriasis, we didn't need that as much because we have amazing drugs that target most of the patients, but it's a much less heterogeneous disease. And I think in atopic dermatitis, we will go likely to that direction.
So how do you think we should do that, Emma? Because my problem for patients in daily practice is that we have patients on dupilumab and also on baricitinib, but they also use, especially the patients on dupilumab, they also use other systemic immunosuppressants. So it's not a clean population. So I think in the ideal world, you would do this already in the clinical trials on which patients only have dupilumab or only have tralokinumab or nemolizumab or any other drug, right?
Yeah, no, I think it's a great question. So I do think that's why two things may help us. One way is the way it's in Japan, that you already have some biomarkers that are approved, like CCL17, and you use it in patients. Or the other way is maybe via tape strips that you can apply to a large number of patients, because you can't start them biopsying everybody, not in clinical practice and not in a clinical trial. Mm-hmm. It's good to do it, but you'll always be able to only do it in a subset. So I think that will allow more flexibility to do it in more patients, potentially.
Right. So you really think that, and I think I agree that in order to do that, you really need the large populations, and getting blood from these patients is it's more difficult compared to tape strips or and the other thing I think is really interesting are the dry blood spots that are being used in neonatal heel prick. So the neonatal blood spots, you can just take a drop of blood, dry it, and send it to the hospital overnight, elute it in the lab, and get your biomarkers from there.
Mm-hmm. Yep.
But tape strips are probably even easier to apply. But I'm not sure if tape strip will be applied also by the patients themselves in the future. Do you think it's possible to ask a patient to do that at home?
You know, that is a good question. The question is whether they will do it in the right way or in the right place. Yeah, that's a good question. It's not painful, but we do not know. So it should be still optimized. But I do think that generally speaking, biomarkers, maybe in the hospital setting, I'm not so sure how feasible it is in the house of the patient setting or
Mm-hmm.
in that setting, but definitely in the hospital setting or in the private practice, maybe we will be able to apply some biomarkers that will help in the thinking about what drug for what patient, in the setting of comorbidities, not comorbidities, and so on.
Are you aware of any large studies, like clinical trials, in which there have been large panels of serum biomarkers or blood biomarkers that have been determined in the primary studies, in the clinical trials, the phase 3 trials? Because I haven't really seen them.
Yeah, I'm aware. I'm aware of some studies that have serum and some tape strip biomarkers in the phase 2 or phase 3 studies.
Right, right. So they're coming.
Mm-hmm.
Right.
Kenji,
So Kenji, what do you think is this? Oh, sorry.
Pardon?
How is it in Japan? What do you think will be the direction in Japan?
Actually, we are probably almost in the same track. But yeah, as you mentioned, I think a non-invasive way to get biomarker is quite important, especially for AD patients. It's very difficult to do biopsy, but we need information in situ, local information, and that is very important, as well as serum biomarkers. And I'm very impressed by your previous study. For example, like a anti-IL-22 treatment is effective for high level of IL-22, but not effective for not so high IL-22 patients. That kind of information will be very important for the future direction.
Yeah, no, I agree. That is a good example because it's a study that for the patients in which it worked, and these were the patients with the high IL-22 levels, it was a really good treatment, and for some of them, it even left them clear for several months. On the other hand, for the patients that it didn't work, and those were the patients with very low levels of IL-22, so for these, it actually made them worse. But here is a study where if you find the right patient, then the results were even better than some existing FDA-approved treatments. And I think that's the whole idea of personalized medicine. And I do think that will be the case in the future, particularly for patients that have particularly like canified lesions, particularly psoriasiform lesions, facial lesions, and so on.
So what do you two think that is going to be the next drug that is, well, the best target for personalized medicine? Because I have a drug in mind that I think might be an interesting one, but what do you think? Like the IL-22 blocker, that's an interesting one, but
that's a very interesting one. But Kenji, what do you think? Let's see if you and I think alike.
Yeah, I think it depends what is the target. For example, for pruritus, maybe nemolizumab anti-IL-31 might be interesting. So, but at the moment, we don't have good biomarkers for choosing treatment yet. IL-22 is a good example, but not so much information we obtained yet. So,
Another target that I think will be interesting to watch in the next few years, and it's the entire class, is the class of the OX40 ligand targeting drugs, because they can get into the Th2 axis, but potentially there is a hint of tolerance maybe, or targeting Tregs. And I think that's another class to watch that may be interesting in all patients, in a subset of patients. We do not know, but I think that may be also something interesting to watch in the next few years. And the other thing that I think will be interesting in the next few years is the idea whether we need to target AD patients with more than one cytokine targeting. Either bispecific antibodies, or the idea that for some patients we may need JAK inhibitors that target more than one cytokine pathway. I think we'll learn in the next few years with the JAK inhibitors also coming to the market.
Mm-hmm. Definitely.
I agree. So is that possible to detect TSLP levels from the tape stripping samples?
Yes, so tape strips are actually very useful for epidermal biomarkers. So yeah, we can detect TSLP and IL-33 and also OX40 ligand and OX40 in tape strips. So the entire axis is possible to detect actually in tape strips.
So DJ, I think your group is one of the top of the world to analyze serum biomarkers. So I think you and your group clarified several subsets of endotypes of atopic dermatitis via serum proteomics, kind of proteomics. Could you explain a little bit?
Yeah, so we definitely, I think we did show that using serum biomarkers, you can distinguish different endophenotypes of patients. So I think we've shown that there are different subsets of patients that can be defined just based on what happens in blood. But I think the next step should be to show that these subgroups do respond differently to different treatments. So the funny thing was that 38% of the patients were in the Th2 high group, which is the same, which was funny, but it was the same percentage in the dupilumab trials that had a PGA 0 or 1, so clear or almost clear. So it would be nice to see if there was, well, the patients in the good responders are really mostly in these two groups, but we don't have that data yet. So I'm really wondering, are we going to wait for pharma to do these studies? Because I think, as I said, I think that the best source for biosamples is probably the big clinical trials, because they're much cleaner patients. But I don't think pharma is going to do the studies we really want to do, is to show the prediction of treatment response. So what do you think? Should we unite and do this together, or what's the way forward?
That's a really excellent point, and I think here is where maybe registries across continents may be so important here, because the plus of registries is that you have also more than one drug. You have a real life situation in which you have different drugs and you have large patient numbers, and it's not only one drug, because the studies done by pharma will always have one drug at a time. So I think registries are very powerful in this perspective. If they are able to collect, not always in registry, all the patients will agree to collect samples. They may agree to get their information, but sometimes they will not agree to also give samples. But if we have enough patient numbers that will agree to collect samples, that can be very nice in a registry. And then, we can unite across the world.
Mm-hmm. But I'm always a bit afraid of the collection, so because samples are being collected in different ways, stored in different ways, and especially when you look into blood, I think it's really important to use the same standard operating procedures, like the time on the bench for serum. So I think it's really tricky to use samples from many different sites, being collected in different ways, stored for different periods of time. Although the techniques are getting better.
I think if they are frozen in -80, the problem starts when you freeze them in -20. But if I think they are stored appropriately at -80, which you raise a very good point, because not every site has the -80. So, if they are stored in -80, and not stored for too long, it should be fine, I think, with the new techniques.
Yeah, I agree. Technical advancement is very striking these days, and I'm very surprised and pleased to hear that Emma's group's paper that we can detect messenger RNA from tape stripping, even from tape stripping. That would be really wonderful technical advancement to search for biomarkers.
Yeah, no, I agree. Lately, we are able, from the same tape strips, to do both mRNA and proteomics. And it's complementary because the proteomics are complementary to the serum. And I actually like the proteomics even more because you can correlate with the serum biomarkers. And I think it's nice to have a biomarker that fully correlates serum and skin. Because ultimately, I think in atopic dermatitis, and Kenji, you raised an important point, I think that the local inflammation is probably the source of what you have in the blood. So I think it's nice to have that ability to correlate. And particularly that sometimes these proteomic assays require very small quantities, which is also important because particularly in children, this is what you have.
Right.
Yeah, we need to remember our main population were largest population is children. So we need to think about ways that are not so invasive in this population.
Mm-hmm. Yeah. So should we move on to the next subject?
Yeah.
So the disease severity biomarkers, because I think we all know that EASI and SCORAD are really showing high levels of inter and intra-observer variability. And I think it would be really cool to have finally have an objective biomarker. And I know that the Japanese have been using TARC CCL17 for more than 10 years now. So how did you get that approved? How did you get the payers to pay for? Because I really want to have that also in the Netherlands, and Emma probably also in the US. But
absolutely.
How do you convince
how do you
them
get it approved, and how also it's done in reality? Like, let's say somebody wants to send. How do you guys do it?
Yeah, I don't know exactly, but atopic dermatitis has been very important disease for many years in Japan. So Japanese government pay a lot of attention how to control atopic dermatitis. That is, I think, one reason. The other reason is Japanese group discovered TARC levels is elevated in atopic dermatitis patients. And that group worked very hard to move Japanese government to approve to use TARC levels as a biomarker for atopic dermatitis. I think that's two reasons. And we've been using for many years, and we can check the TARC levels once a month.
So there is once a month it's approved by the insurance. So if somebody wants more than once a month, they need to pay out of pocket.
Right, that's correct.
but still, so did you have to show like that it increases that it has additional value? So after when it was introduced, like within 5 years or so, did you have to show to the government that it increased the quality of care? So you had to. Okay, so
I think
because these reports are not public, I guess. It's probably in Japanese, right?
Yeah. No, what DJ is aiming to get to, and I think he makes a very good point, that if we knew what you guys did, maybe we can adapt it in other countries. Because it would be useful indeed to have an easy to do biomarker that you get it next day or the day after, not in a research setting, but in a certified, CLIA certified lab. Right, DJ? I think that's what you're getting.
Exactly, yeah. Because we used to do that in Utrecht for a couple of years, but it's really costly because when you have your lab to do that, it's like over 30 euros or dollars per sample, probably even more. But the patients were really happy with it because they saw when they applied a lot of topical steroids in the right way, the eczema was better, but also the levels went down, and it feels like Kenji and I are both on Strava, so we inform. It feels like getting kudos, right?
No, absolutely. I think you brought a very important point. I think engaging the patients and making them feel that they are part of the decision making, then they are also more inclined, I think, to give biomarkers, to participate in research. Otherwise, they will not have any incentive to do that, real incentive. But if they feel that this will, first of all, help their disease clearance, or it will be a step up in taking care of their AD better.
Exactly. Also, on the patients that we now have on the dupilumab or on JAK inhibitors. So they come from really, really bad. They are much better after 3 months. They're really happy, and then after 6 months, they look back and they don't exactly remember where they came from. And when you have like objective numbers to show you, well, you were at like 7,000, the numbers went down to 300, and they're still at 300. I think we did a great job. It really works also in daily practice.
Yeah, no, that's a very good point, is how do we define response also? Because there are some patients, and I don't think, for example, EASI 50 or EASI 75 are such good measures to define response, because there are some patients that for them, like you say, they went from 100% of the body to having, let's say, 20% of the body. So it's a huge improvement. But these patients, many times, they may not achieve exactly hardcore responses on. So that's why I think biomarkers are also important to have a more granular measure of improvement.
I agree.
Exactly. Yeah.
So that will lead to improve the relationship between patient and doctors, and also increase the motivations for the patients to treat the disease. So
absolutely, because I think for many years these patients were very disappointed in the care that they got, and we didn't have good means to treat them. Every time they would get the same medications, the disease will come back after they stopped. It was a cycle, and I think now we are engaging them in a process that I think is much better to have disease control at the end.
Right.
How are in Europe and in Japan patient organizations? Are they part of this search for biomarkers? What do you guys feel? Do they partner with patients on this?
So Kenji, go first, please.
no. Please go.
So in the Netherlands, we do have, especially since the introduction of the first biologic, there's been money and also the patient groups, the support groups are getting stronger, and we also are being pushed to involve them in when we have project proposals, and I think it's a great thing to get them on board really from step one in research. So yes, in the Netherlands at least. We do get the patients involved in research, also in biomarker research from early on, and they have sometimes really have excellent ideas. So they think more out of the box than we do.
Yeah, no, I'm sure. Yeah, no, I think it's a very good idea to involve the patients in decision making and thinking about biomarkers, and maybe showing them also some data to motivate them to do more.
Right. I think in view of time, we should move on to the last topic, which is predicting, for example, the disease trajectories, the comorbidities, atopic disease comorbidities. Do you think, Emma, that with the tape strips, that will be the tool for birth cohorts to start looking at expression of genes and proteins early in life?
I do think that probably that's the case, because serum you will get in some, but not in all kids, and particularly more the older ones. It's hard in that age group to get a serum from all the kids and get all the patients and parents to agree to that. So yeah, I do think that that probably will get to be the main tool for birth cohorts, and I do think it's an important point. And particularly when we'll also have drugs going into that age group, and then we can see if the drugs predict maybe who will outgrow the disease, or if the biomarkers will predict who will outgrow the disease with good treatment, and maybe also predict who will not develop other atopic manifestations. I'll give you an example. Let's say a child has two parents that have asthma and AD, and that child with good treatment of the disease will not get the other atopic comorbidities, the asthma, for example. So I do think that this will play out in the next 5 years, probably, with good treatments going into that age group.
And are the tape strips already in can you really use them already for birth cohorts? Is it good enough
I'm involved in a birth cohort study that has tape strips. It's a birth cohort study, actually, not of AD patients. It's from the general population, trying to understand who will develop AD and maybe who will outgrow it. But yes, I'm also aware of a US birth cohort that is going to look at children that are already with AD.
Cool.
So I do think that that will be something that the future will tell us. It's exciting times, I think, in general, in atopic dermatitis and for our patients.
I agree.
So how about serum biomarkers for trajectory in your serum study?
Yeah, well, I'm not really looking too much into children. So I think if you want to look, if you want to predict the disease trajectories, you really need to look early in life, like with the NMF, so with the natural moisturizing factor in newborns, or in blood, umbilical cord blood, for example. But getting blood from well, 3-week-old children, I think that's a pain, right?
Yeah.
And then you have to wait
Yeah.
until they develop or not develop comorbidities, and then look back. So I think it's a long-term investment. It's an interesting one and it's an important one, but I think that's probably a much better role for tape strips in these children or dry blood spots.
I agree. I think the serum is important in adults where you want to learn about developments of other comorbidities such as alopecia areata, vitiligo, that we do see in our patients with atopic dermatitis, maybe particularly alopecia areata, and how they respond to treatment in the other comorbidities as well. I think that's important, particularly, for example, a patient with atopic dermatitis and asthma, both of them will have a serum abnormalities. So I think that will actually give you a clue. But I think in children, probably tape strips are better.
Right. I think in view of time, I think it's time to wrap up, right?